Hi everyone. Uh, this in this video, I'll discuss the management of endometrial cancer, stage 1, stage 2, with incorporation of molecular-driven pathway. This will incorporate some of the recent guidelines and some of the data based on my interpretation. So some people may manage things differently, but I will discuss pros and cons of the approach. So we know that it's the most common gynecological cancer in developed country. In 2012, it occurred in about 320,000 women and caused 76,000 deaths. It's the third most common cause of female malignancy death behind ovarian and cervical cancer. And the incidence is rising because of increasing age and also increasing obesity. Now, sentinel lymph node biopsy has become standard of care for endometrial cancer based on FIRE, STRO, and CENTO data. The sentinel lymph node detection rate, depending on how you interpret it, is 89 to 97. Unilateral in 40 to 87% of the time, and bilateral in 58 to 77% of the time. The nodal positivity rate, based on what study you look at and what histological type you look at, is from 12 to 22%. The sensitivity is 95 to 98%, but most importantly, the negative predictive value is very high. So that means the sentinel lymph node is negative, the more than likely patient has node negative disease, which is important for the management purposes. And not unexpectedly, it causes less lymph edema. This part of the presentation will only cover adjuvant treatment for stage 1 and stage 2 endometrial cancer. I will not cover stage 3 and stage 4 disease. So the risk factor for the recurrence is either clinical pathological or more recently molecular type. Clinical pathological is age, with advanced age being adverse prognostic factor, grade of cancer, adverse pathology like UPSC or clear cell, extent of LVSI, non-focal or the substantial, which has various definition, but for practical purposes, people use 4 or more vessel involvement, and stage of disease. The molecular type is also prognostic, with the poly type being the most favorable type and P53 being the most aggressive type. In between is MMR deficient, not otherwise specific type, low grade, ER positive being a bit more favorable than ER negative disease. The incorporation of molecular subtype into the early stages has come from the combined analysis of PORTEC 1 and 2, which had arms which got no radiation therapy, brachytherapy, or external beam. When you look at the outcome combining both the studies, the polytype had excellent outcome, as you can see from the graph. The MMR deficient had the impact of adjuvant treatment was much more smaller. The maximum impact of adjuvant treatment was in P53 type. You can see that there is significant separation of the curve, more so with external beam radiation therapy. And the last but not the least, NSMP, there was benefit of adjuvant treatment, but much smaller in comparison to P53 type. So it shows both the prognostic significance in terms of overall outcome was much better for the poly type versus P53 type, and the impact of treatment got much more as the prognostic got worse, with P53 benefiting the most. So this graph shows that why do we further refine NSMP based on the ER receptor status. You can see in the NSMP group, ER negative and ER positive are independently associated with different outcome, with ER positive disease having much better relapse-free survival compared to ER negative disease. And also ER negativity was associated with more aggressive histology, high grade, non-endometrial histology, and L1 gamete overexpression, which are all adverse prognostic factor. So it's important to understand that a small subset of endometrial cancer patients have multiple classifier molecular characterization. That means they have more than one molecular subtype. Like in this one of the largest study of about 3,500 patients, about 3% of the tumor displayed P53 abnormality in addition to another classifier. About 64 of them have MMR deficient and 31 of them had poly mutation. And 12 had 3 aberrant mutation, including P53, poly, and MMR deficient. The important finding was most of these dual or triple classifiers were associated with grade 3 endometrioid histology. And if you look at it, 18 out of 28 of MMR deficient and P53 abnormal, and 7 out of 15 of polytype and P53 abnormal showed subclonal P53 overexpression, suggesting that the P53 mutation was a secondary event, and that's why the prognosis is driven by the favorable type, not by the P53 type. And this shows the outcome. If you look at the outcome of double classifier, you can see once they are MMR deficient or polytype, irrespective of P53 status, their outcome is much better compared to P53 abnormal single classifier type. And so it's important to understand that, because once we start using molecular classification in our management, it is important that we do know polytype status. Without knowing polytype status, you would not know whether it is dual or triple classifier. And sometimes we can overtreat this patient just because of the fact that P53 abnormality itself may not be the driving factor in this patient. And that's important messaging from this slide. So that's why if you look at the recent guideline from ESGO, ESTRO, ESP published in Lancet in 2025 in August, they always say that if you are going to use molecular classification, start with poly mutation analysis, because if they are polytype, then that will drive the prognostic factor. But if they are poly negative, then you can go on to check for mismatch repair or P53 mutation. And if they have mismatch repair positive, that means they are MMR deficient. If their mismatch repair is retained, then it could be either NSMP type or P53 type. If they're NSMP type, you again do ER receptor status, because if it is ER positive, low grade, then they have different outcome. If it is ER negative or high grade, then they have different outcomes. So knowing grade and ER status is important for NSMP type. While for P53 type, if they are wild type, then we are good. But if they have heterogeneous or equivocal expression, then they suggest P53 sequencing to classify whether it is truly P53 type or not. So it's important that if we are going to use molecular classification, we follow this schema of thing, because not knowing polytype can overtreat some patients. And then even for NSMP type, you need to understand whether it is low grade or high grade, and whether it is ER positive or ER negative. And this would guide you through the course of treatment just based on the guideline and some of the available data. Another anatomical adverse factor is the substantial LVSI, which is a significant factor for recurrence in endometrial cancer based on the pooled analysis of PORTEC 1 and 2. If you look at PORTEC 1 and 2, they found a 3-tier system was prognostic, with no LVSI having 5-year pelvic recurrence of 1.7%, focal LVSI 2.5%, but substantial LVSI, which at that time they used the definition of more than 1, but subsequently there has been a revised definition of 4 or more vessel involvement, and that predicted the risk of recurrence to 15.3%. It also was independent prognostic factor for distant metastasis and overall survival. And when they did this subgroup analysis of this substantial LVSI, whether they got external beam or brachytherapy or no additional treatment, the maximal impact of the treatment was to external beam, where the risk of pelvic recurrence was 4.3%, while with no additional treatment of brachytherapy, it was still high. So they suggested that adjuvant pelvic external beam radiation therapy is indicated in patients who have substantial LVSI based on high pelvic recurrence and significant reduction of the pelvic recurrence external beam. But the problem is, in PORTEC 1 and 2, the nodal assessment was not done. So we don't know whether substantial LVSI was an independent prognostic factor, or whether it predicted for higher nodal involvement, and that's why patients benefit from external beam. So this is one of the largest retrospective analysis from our institution, when we looked at what is the incidence of LVSI in comparison to what was reported in PORTEC. And we found that the risk of LVSI was significantly higher than what was reported in the PORTEC analysis. We can see that the no LVSI was present in 67.4 or 50.8% based on inclusion criteria. But importantly, the substantial LVSI was very high, 16 to 25.1%, depending on whether you look at overall cohort or the one with PORTEC criteria, depending on 4 to 5% seen in the PORTEC study. This brings the questionability of reproducibility of this so-called 3-tier LVSI system unless it is standardized. And then also, one other important factor was of the patient who underwent surgical lymph node assessment, the extent of LVSI predicted for risk of nodal involvement with 3.3% without LVSI, 7.5% with focal LVSI, and 15.2% with substantial LVSI. So that speaks for the fact whether the benefit of external beam radiation therapy in this subset of patient was probably because of treating the occult lymph node which were not assessed, or whether it is independent is a question still to be answered. We also looked at what was the prognostic significance of patients who had sent in for biopsy or lymph node dissection done and had substantial LVSI. So we analyzed about 300 plus patients who had pathological lymph node negative disease, either by sentinel for biopsy or by nodal dissection. The substantial LVSI was present in 17.6% of the patients, similar to what I reported before, and out of which about 40% got brachytherapy and about 7% got external beam. But there was a higher indication or higher number of people with substantial external beam because that was a prevailing factor in deciding about radiation therapy. In patients who had focal LVSI, about 81% received brachytherapy. And among patients with substantial LVSI, you can see about 58% received brachy and about 31.6% received external beam. But importantly, in this so-called surgically staged patient, the 2-year loco-regional and disease-free survival was not different whether they had no LVSI, focal LVSI, or substantial LVSI. Similarly, the risk of distant mets were very similar. So in our institutional study, patient with pathological lymph node negative disease, substantial LVSI had significant outcome, both for loco-regional recurrence and distant mets, which was very different than what was seen in PORTEC 1 and 2, bringing into the question whether we can have similar prognostic value to substantial LVSI in patients who have nodal assessment done. And we talked about it, sentinel for biopsy has a very high negative predictive value. So in those patients, what is the true value of external beam still needs to be determined because our retrospective analysis did not show the impact. So this is the FIGO 2023 staging system, which takes into account the molecular subtype if you have that information available. If you don't have that information available, then they take anatomical information. And the stage 1 is stage 1 with and without myometrial invasion and the extent of myometrial invasion. Stage 2 had 2 categories, cervical stromal invasion without substantial LVSI or cervical stromal with substantial LVSI or any stage 1 disease substantial LVSI. On your right, you can see the molecular classification being part of it. And you can see a different color, the green, the yellow, the orange, and the pink. So the one in the green is the low risk disease. And that means the risk of recurrence is low. And the additional benefit of adjuvant treatment is very limited. The one in the yellow is intermediate risk disease. The one in the orange is high intermediate. And the one in the pink is high risk disease. Of these, you can see the most important prevailing factor is the polytype, which drives the patient to low risk disease. And the most important factor is the adverse pathology or P53 abnormal type, which drives the patient to high risk disease. In this category, they do talk about the fact that if somebody has stage 1 disease with P53 abnormal status, the true risk category of these is not known, the one in purple, because the outcome data is limited. It does suggest that they have high risk than low risk disease, but how high is a matter of debate because we don't have too many outcome data. So in the ESGO guideline, they do take this so-called subclassification into account and decide for the treatment based on the risk category. So this is how the ESGO define it. Low risk is less than 8% risk of recurrence. Intermediate is 8 to 15% risk of recurrence. High intermediate risk is 16 to 25 and high risk is more than 25. And what type of treatment to offer is based on risk category with absolute benefit varying based on what risk category the patient belongs to and what is the impact of adjuvant treatment. So the low risk disease classically has been stage 1A, grade 1, grade 2 endometrial histology. They lack high risk features such as LVSI. But if you look at molecular classification, then it is stage 1A low grade disease, either polytype of MMR deficient or NSMP-ER negative. The stage 1A high grade disease, polymutation or MMR deficient. Stage 1B or stage 2 polytype, including substantial LVSI. And the estimated risk of recurrence is less than 8%. So overall, it classifies both based on on the anatomical and the molecular type. But this subtype, like stage 2 with substantial LVSI polytype, the available data is limited. So in my own practice, I do take this into account, and I not necessarily treat them like low risk disease, especially if they do not have nodal assessment done. But that being said, that's what the SGO classification does. But we need to understand that they are not, like some of these so-called subcategories are underrepresented, and whether polytype would trump over any one of these adverse abnormal anatomical factor, including substantial LVSI and stage 2 disease, is still to be seen. But that being said, sometimes like in the SU, they do also mention that if you have somebody with stage 1A, grade 1, grade 2 endometrial histology, which meets a classical definition of low grade disease, then you may not need to do molecular type because you'll observe most of these patients to begin with. The importance of polytype comes in when you have high grade disease, because some of these high grade diseases are polytype, and that's where importance of having molecular classification comes in. So not necessarily stage 1A, grade 1, grade 2 benefit from molecular classification. You can safely favor observation. But if they have high grade, then knowing that type could sometimes have you do better prognostic signification. So if you look at for low risk disease, we have one randomized trial, the Swedish study, which randomized them to brachy versus observation. And as you can see, there is non-significant reduction in cough recurrence with some grade 1, grade 2 side effect, including dysuria frequency and incontinence. 2.8 versus 0.6, low risk to begin with, but supporting the paradigm that the so-called low risk disease could be observed following hysterectomy. Now, PORTEC 4 was presented at ESTRO this year, and for those who don't know, the design of the PORTEC was based on molecular typing. So stage 1 endometrial cancer were randomized 2:1, high intermediate risk category. The standard arm was brachy for all, and the experimental arm was based on molecular classification and presence and absence of substantial LVSI. So if they had favorable type, polytype, stage 1A, grade 1, it's a polytype with absence of substantial LVSI, then they were observed. Most of the intermediate type, they got brachytherapy, and the high risk type, which was basically substantial LVSI or having features like P53 mutation or LCA mutation, then they were offered external beam. So basically, the stage 1A, grade 3, stage 1B, grade 1, grade 2, more than 60 or LVSI, and stage 1B, grade 3 without LVSI were included in the so-called high intermediate risk category. And the dose was 7 gray times 3. So you can see this was a molecular classification used. If you are polymutation type or MMR with wild type, then they were favorable. Intermediate was MMR deficient, and unfavorable was substantial VSI, P53, or more than 10% LCAP. So this was a small subset, supposed to be between 5 to 10%, and the most common type was supposed to be low risk disease. So if you look at the results presented at the ESTRO, about 564 patients randomized either to molecular-based treatment or brachytherapy alone. In the molecular group, 46% were observed, 40% was brachytherapy, and 14% turned out to be high risk compared to their anticipation of about 5% or so. The local regional recurrence was similar in both the group. The pelvic relapse rate and the cuff relapse rate was you can see the pelvic relapse rate, there is no difference, and cuff relapse rate, there is no difference between the groups. So there is no difference in local regional relapse rate in the two groups. There's no difference in disease-free survival and overall survival. When they looked at the favorable profile type, which was observed in the experimental arm, there was about small difference in vaginal recurrence, 4.7 versus 0.9, but they predefined equivalence margin of 8.5%. So it was considered to be non-inferior. Now, again, some people can make an argument that 8.5% is too high for this low-risk disease. Sometimes brachy alone has low morbidity, and patient's choice and informed decision should be taken into account, because some women may want brachytherapy just because of the fact that it's a low-risk procedure and there is some difference in outcome. In the exploratory analysis, not unexpectedly, they found that the local regional recurrence was much higher in the high-risk category if they got only brachytherapy compared to external beam. You can see 30.5 versus 8.4%. Again, to understand that these patients did not have nodal assessment done. So basically, it established the prognostic group. The low risk had low risk of recurrence, smaller benefit with brachy. Intermediate risk did very well with brachytherapy, and the high risk group benefited from external beam based on their risk categorization. So for management of low risk disease, like as I said, since it is a favorable profile with small difference local recurrence, not meeting, like it was below the predefined equivalence margin. So the conclusion was observation for this category. But as I mentioned, some people may consider that to be uh, not an acceptable non-inferior margin and may discuss with patient pros and cons, especially if they have some adverse anatomical factor. Now, intermediate risk group has various definitions. It has changed over a period of time. It generally includes stage 1, stage 2 disease with deep myometal invasion, high grade, LVSI, older age. Both PORTEC and GOG99 use different definition. Some were intermediate and some were high intermediate, but I'll discuss some of it. But in general, it is 60 and above stage 1A grade 3, stage 1B grade 1, grade 2 with no substantial LVSI. That's the old anatomical definition of intermediate risk. In the molecular era, it's stage 1B MMR deficient or NSMP low grade ER positive, or stage 2 NSMP low grade ER positive. So basically, if you have ER positive NSMP or stage 1B NSMP ER positive MMR deficient, you are considered intermediate risk disease. And there are some studies which have defined what should be done for intermediate risk disease. These are PORTEC 1 and 2, GOG99, Swedish, Norwegian, ESTRO, and Japanese. I'll discuss some of it in brief. So you can see this is GOG19 and PORTEC 1. There is some difference in inclusion criteria. They defined intermediate, but there was some overlap. Again, randomized to observation versus brachytherapy. And you can see there was small difference in risk of relapse, but overall there's no difference in survival. And not unexpected, there is higher morbidity with external beam radiation therapy with significant negative impact in quality of life and symptomatic GI side effects in the patient who got external beam radiation therapy. You can see more diarrhea, more fecal leakage, more limitation in daily activities, and need to remain close to toilets, which are all significant factors. But need to understand these were old 2D technique, not necessarily modern day IMRT and IGRT, which has shown to have significant improvement in patient reported and physician reported both acute and chronic morbidity, and that is now the standard of care if patient needs external beam. So the conclusion from these studies was EBRT reduced risk of pelvic relapse by 75%, but about 75 to 80% of recurrence were in the vagina. There is increased GI morbidity which affect quality of life with the external beam, and there is no difference in survival. So these are the 4 studies which had component of brachy alone versus external beam radiation therapy. You can see the dose of external beam varied from 40 to 46 gray. And if you look at all these 4 studies, there was small difference in local relapse from 7 to 2%, 6 to 3%, 5 to 1.5%, or 5.1 to 2.1%. So 2 to 3% difference in local region relapse, but no difference in overall survival, and not unexpectedly higher morbidity, both bowel and urinary, affecting quality of life because of the external beam radiation therapy. So you can see the quality of life impact from PORTEC 2, and you can see higher impact on global health, as well as rural functioning, as well as social functioning. No difference in sexual function, but other ones were more negatively affected by external beam. So if we conclude, EBRT associated with slightly lower risk of local regional relapse, 3 to 5% in comparison to brachytherapy, no difference in survival. Not unexpectedly, brachytherapy had less impact on long-term quality of life in comparison to external beam. So for these intermediate risk patients, brachytherapy is the reasonable option. That was the reason why in PORTEC 4, they were defined treated with brachytherapy and continued to show excellent outcome in the so-called intermediate risk patients. So brachy alone, and then the ESGO guideline do say that if you have low grade and less than 60 years old, one can observe also understanding pros and cons of smaller absolute benefit of brachytherapy. So how do you do brachytherapy? As I said, brachytherapy is effective in reducing the odds of recurrence. The morbidity is very low. Most of them are like grade 1 to 2 urinary morbidity and some grade 1 to 2 vaginal toxicity, as seen in the prospective randomized trial comparing brachy to observation. So the commonest fractionation schedule is 7 grade times 3 prescribed to 5 millimeter, treating upper 1/3 to upper half of the vagina. I normally treat 3 centimeters of vagina. There are other effective lower dose regimen, 6 gray times 5 or 4 gray times 6. Since they are lower total dose, they have less vaginal toxicity, and they have reported similar vaginal control rate. More recently, the SAVE group reported 2 fraction regimen, again showing similar local regional control as expected and less morbidity. So there are 2 fraction regimen. I commonly do 3 fraction 7 gray times 3, but there are 4 or 5 fraction regimen. They are not equivalent dose. You need to understand that's why what is the correct dose is still not known. So the reason why 6 times 4 and 4 times 6 have less morbidity is not because of fractionation necessarily. It's also because of the fact that the total dose is much lower in comparison to 7 gray times 3 at 5 millimeter depth. I favor CT-based simulation. It confirms the placement of the applicator to the apex. It identifies rare but possible cup dehiscence. You can also document the dosimetry for bladder, rectum, and sigmoid. In case patient comes back with a recurrence, you have the previous dose, which can help you plan for the salvage treatment, which is important. You don't, and the other thing is, we don't benefit much from dosimetry or replanning from fraction to fraction, but you still need to confirm with imaging the placement of the applicators in the correct position, which is what we do. So we plan for the first fraction, document the dose of rectum, bladder, and sigmoid, and for the remaining 2 fractions, just confirm with the CT simulation to make sure it's in the same position. So the third risk category based on ESGO, which I showed you in the graph, is high intermediate risk. Like it's stage 1B grade 3 by anatomical classification, stage 1A grade 3 with LVSI, a stage 2 disease. But when you look at molecular based classification, it's stage 2 any grade if it is MMR deficient, or stage 1A, 1B with substantial LVSI, MMR deficient, or NSMP low grade type. So if you have 1A, 1B with substantial LVSI and it's non-poly, it is MMR deficient, NSMP low grade ER positive, then it belongs to high intermediate risk category. And as I said, the risk of recurrence in this category is around 16 to 25%. So EBRT is the preferred treatment, but that being said, for surgical stage with nodal assessment, and I favor brachy alone for a lot of these patients, unless there is significant cervical stromal invasion, then I do favor external beam. But nodal assessment has to be accurate. As I said, sentinel lymph biopsy has high negative predictive value and it is well documented. Then I favor brachy alone. But that being said, external beam is the preferred treatment, but selectively you can do brachy alone, looking at the overall picture as well as surgical stage information. The high-risk disease is stage 1A, 1B adverse pathology and stage 2 adverse pathology by standard definition. But if you use the molecular classification, stage 1A, stage 1 and stage 2, NSMP ER negative or P53 abnormal. Now, I'm not going to discuss stage 3 and stage 4 disease, but in the ESGO guideline, stage 3 and stage 4 is also included in high-risk disease because they also have risk of recurrence more than 25%. One thing important to realize that even though stage 1A, a P53 abnormal or NSMP ER negative is considered high risk, the outcome data on disease confined to the polyp having adverse pathology with P53 abnormality or NSMP ER negative is very limited. They tend to have higher risk of recurrence than low risk disease, but we do not know what is the true impact of the treatment. So that's something which is underrepresented, and they do acknowledge that it is something which we don't know the true risk category, but some people treat them like high risk categories, but others would treat them based on individual risk factor. For high risk disease, the options are chemo plus EBRT, concurrent, adjuvant, or sequential, chemo plus brachytherapy, or even for some patients, external beam alone, because as I said, the value and impact of chemotherapy is not necessarily established in all stage 1 disease. And brachytherapy alone is only for adequately surgically staged patients. So it's important that the high-risk disease, the surgical staging is very important because the risk of nodal involvement is high, and if they're not staged, external beam is preferred. So, we do have a couple of randomized trials for so-called high-risk stage 1, stage 2 disease. Like GOG49 is the one often quoted, plus there's a Japanese study, which did include some higher stage disease. So in GOG249, if you look at it, included stage 1 high intermediate risk based on GOG99, But it also included stage 1, stage 2, serous and clear cell, which is what the current definition of high-risk disease includes. The randomization was vaginal brachytherapy with 3 cycles of Taxol and carboplatin versus external beam radiation therapy alone, which was standard of care. When they reported there was no difference in vaginal recurrence, but there was significant difference in pelvic and parodic recurrence with favored external beam radiation therapy, with like 4.4% external beam arm versus 9.2% vaginal brachy plus chemo arm. No difference in distant mets, no difference in overall survival, more GI and heme toxicity with chemo. So the conclusion from the study was external beam radiation therapy remains standard of care. So, the GOG 249, most majority had nodal assessment done, but as I mentioned before, in most of the PORTEC 1 and 2 study, nodal assessment has not been done. So PORTEC 1 had a separate subset of study of stage 1C, which is now stage 1B with deep myometric invasion, grade 3, which included adverse pathology also. They had single arm 99 patient study, nodal assessment was not done. And you can see the 5-year overall survival was low, like for 1B, current 1B grade 3, 58% with high risk of distant metastasis. So external beam did decrease pelvic relapse, but distant mets was high, probably because of under-assessment in nodal stage and inclusion of high-risk adverse pathology also. So they did conclude that, 1C grade 3, which is now 1B grade 3 at high risk of distant mets and cancer-related. So you can see two perspectives, one with nodal staging with brachy versus chemo plus external beam, the other one just looking at external beam. So it appears that external beam is preferred for this high-risk disease, stage 1, stage 2 adverse pathology or other high-risk category which I've defined before. Chemo plus vaginal brachytherapy is emerging as an alternative and is still practiced, although it is not superior to external beam alone. But that being said, for papillary cell and clear cell, most of the GYN oncologists prefer chemotherapy. So that either you combine with brachytherapy or external beam based on whether it is surgical stage or not, and what's anatomical staging. If it is stage 1A, I prefer brachy alone, but if it is stage 1B or anybody with substantial LVSI, I do favor external beam radiation therapy as part of the treatment. So if I have to conclude, the so-called low-risk disease which I mentioned, where the risk of recurrence is like less than 8%, you observe based on both anatomical staging and molecular staging. Intermediate risk is brachy alone. High intermediate risk, external beam for majority, but you can consider brachy alone for nodal stage patients. And high risk disease, external beam with and without brachy boost, depending on the practice pattern. But if you do external beam, then IMRT, VMAT with IGRT is a preferred treatment because it causes both less acute and late toxicity, as seen in the PORTEC trial and the RTG trial, which showed both physician reported and patient reported acute and chronic morbidity was significantly reduced with the addition of conformal IMRT. So this is from the ESTRO SGO guideline. You can see low risk disease, no adjuvant treatment. But I did mention that looking at pros and cons, one can discuss, because some may consider that 8.5% non-inferior margin may be too high, and in patients with adverse factor. And then again, as I mentioned, that even though for stage 2 substantial LVSI polytype, they recommend observation, but these have been underrepresented in the clinical studies which have been reported, and whether we can completely exclude anatomical staging is still unknown. Intermediate risk, brachy alone for majority, selectively you can consider for observation. High intermediate risk, external beam for majority, but selectively for no surgically staged patient, you can do brachytherapy alone. And high risk disease, external beam with and without chemotherapy, and the chemotherapy could be concurrent, adjuvant, or sequential. Now, in their definition, high risk also includes stage 3 and stage 4 disease, which I did not cover, but that's also part of the high risk disease. They do mention that the stage 3, stage 4 polytype, the answer is not known whether we need to give external beam or not. The data suggests they don't benefit from chemo, but the rainbow trial will give us some answer. So the discussion so far today has been mainly for stage 1, stage 2 disease, dividing them in these 4 categories, and some of the nuances I've discussed based on my own interpretation of the data. But again, I said things may change and people may have different interpretation, but overall this gives you an overview what to consider when you have molecular staging available, and if you don't have molecular staging available. But for molecular staging, one thing is very important, that if you have high-grade disease, you do not follow P53 pathway or the other subtype pathway if you have done polytype. So it's because, and secondly, the double classifier and triple classifier, the favorable type predominates prognostic and not the unfavorable type. With this, I conclude. Thank you for listening and hope it was helpful. Thank you.